a lot of familiar faces, some new faces as well. But we're going to start today. It's a program of 2 parts. So to start with, we're going to have Sonia Neary, and Sonia, I'm going to try to read this out as accurately as I can. CEO of patient communication platform Wellola, and I think you're being joined by James as well. James Warwick-Adkins, who's business development and commercial partnership lead Wellola, and you're going to be talking about transforming hospitals with digital preventative healthcare. That's going to be interesting. So you're the first half of today's hour, and then we've got Bethany Allen, digital nurse at the Christie NHS Foundation Trust, who's going to be talking about enabling better communication with technology to improve cancer care. Look, 2 fantastic topics. I know that you're all going to be magnificent at this. So Sonia, shall I just hand on to you? Would that be okay? Or did you want to have a little chat with me first?
No, that's perfect, John. Many thanks. I'm delighted to be here.
You can talk. I mean, why don't you just tell us a little bit about Wellola first of all?
Yeah, sure, of course. So I'm Sonia Neary, for those of you on the call that I haven't met before. I'm the CEO at Wellola. I'm a chartered physiotherapist by trade, so I would have worked clinically for about 15 years in public and private sector. And I'm also very kindly joined by my COO, Lindsay Watson, who actually also is a physiotherapist. But for us, our vision is that you should only be cared for in a hospital setting if you're acutely unwell. And to that end, the vision of the company is about delivering digital tools to support community-based preventative care delivery. So I'm really delighted to be here today. I have a small presentation. I'm happy to share it, or whatever method works for you, John.
You go ahead. I've highlighted Lindsay as well, or spotlighted Lindsay as well. Lindsay, if you decide you don't want to be spotlighted, you've only just kind of looked me in the eye like that. Are you sure? And I'll quickly get,
That's absolutely fine. Thank you very much.
All right. Well, look, on to the both of you. Thank you so much for presenting today.
Thank you. Just to see if you can see my screen okay. Can you see it?
Yeah, we can see all of your slides at the moment.
Okay, perfect. So I suppose, thank you. So just briefly, I suppose I've been asked to sort of speak for about 20 minutes with an opportunity for Q&A in the sort of final 10 minutes. I may not take 20 minutes to get through this presentation, but I'm very keen to hear your thoughts and questions and queries and make it kind of an interesting discussion, I suppose, open the floor up when I've finished presenting, if that's okay. I'm just going to hide this little button here and come back in. Yeah, okay. So I touched on the point that, that I was a physiotherapist in a past life. When I worked as a physiotherapist in the hospital setting, a lot of the time, most of my patients were orthopedic patients. Those patients had a lot of information about them in the hospital setting. So as a physiotherapist, I would have a patient health record, I would have an electronic health record, I would have their blood tests, their x-rays, their op notes, lots of really rich information about what was happening for that patient. And then say that patient went home after a total knee replacement. We'll call him Joe. Joe's at home. Joe has a nasty wound on the front of his knee. It's oozing. He's feeling nauseous, so he stops taking his antibiotics. He's in a lot of discomfort, so he stops mobilizing. He starts feeling quite anxious and depressed, and his quality of life becomes quite poor. And he probably ends up coming back in the revolving door of the hospital system. So the problem, I suppose, with that is that there's a lot of very rich data about John in my hospital setting and in the community, lots of rich data about what's happening for him in the community, but there's a massive disconnect. And what that means is ultimately we're not getting the best outcomes for the service users of our system. That, thankfully, is starting to shift. So this model of acute, reactive, illness, wellness care is moving towards what we call a sort of a shared responsibility care model, where the patient is front and center in terms of owning some of the responsibility for their care alongside their caregiver. It's really interesting to see this dynamic, particularly since the pandemic. I don't know about you, but certainly for myself, it was the first time during the pandemic that I did a medical test for myself in my home environment. So that's opened up a sort of a change in perspective for a lot of citizens, where they're kind of thinking, okay, well, actually, I was able to manage that and test that and report the results back to my medic if needed. So it's kind of a shift in thinking about giving them room to care for themselves in a home environment. And interestingly, and this was a report that came to us from Accenture last year, 2020, about 60% of patients want to use technology more to care, to receive care or to engage with their healthcare provider. During COVID, about 41% of those interviewed used video conferencing, for example, to communicate with their healthcare provider for the first time. 44% started using apps to manage their health conditions, and perhaps a little frighteningly, about 5% or so of Google searches are related to people looking up their health conditions. And wouldn't it be great if that were evidence-based data that they were looking at that was perhaps curated by their care provider? So, we know that this really outdated model of care and way of communicating with citizens is really, really expensive for the healthcare system. And it's very cumbersome on already really busy healthcare staff. And these are the stats, a little bit out of date, but not too different today from the NHS in 2019. Approximately 8% of all outpatient appointments are no-shows. And we know that this costs the system a huge amount in terms of paper, post, no-shows. But interestingly, some of the Johns Hopkins hospital at home care models would also suggest that caring for people at home can offer huge savings to the healthcare systems that care for them. So what do we all want to achieve? We want to work less and we want better outcomes in terms of communication costs, in terms of administration time. We want to reduce cancellations and no-shows. But most importantly for me are the two last points. We want to improve and increase staff and patient satisfaction. And we want to engage and empower patients to participate in this shared care model. So when we talk with some of our customers, and I'll touch a little bit on the use cases in a moment, these are some of the things that they think about when they're looking at digital transformation. So, typically we're not saying, okay, there's a paper process, let's completely swap out the as-is process for a digitized to-be process. We're looking at how can we enhance the process? What can we change about the process rather than swapping out like for like, one in a digital format, one in paper? What can we actually do when we digitize something to enhance the experience for our team and for the people that we care for? So looking at that, there are sort of touch points throughout the care pathway, pre-entry to the hospital setting, during the care within the hospital, and post, where certain aspects of that care pathway could potentially be digitized and certain aspects must be in person. Also with the consideration that digital is not for everybody. And when we implement something digitally, we don't want it to create additional exclusions in our healthcare system. We want it to optimize access to the healthcare system. So really looking at what parts of our care pathway are suitable for digitization and which are not. What kind of tools are available to us in the marketplace to optimize this digital care pathway? Are they sort of touch point solutions? Are they platform solutions? Do they stand alone? Do they integrate? And what's really fantastic at the couple of sites that we're working with at the moment is that they always bring in patients and their carers and their proxies early on in terms of discovery around what systems they want to implement and what concerns patients have around potentially part of their care being delivered digitally. And equally, on the staff side, this is huge behavioural change. We're asking people to move from the status quo to something that's relatively new. It needs to be seamless, it needs to be effortless, and it needs to make their day easier. So looking a little bit closer, when you're choosing a tool, I think some of these are a given. Once you can see that an organization is on an NHS framework, it's ISO 27001 certified, DCB 0129 compliant, meets certain standards around cyber essentials, interoperability, DTAC, etc. I think we can make certain assumptions around the safety of the product, not omitting clinical safety and all of the importance that goes with that. So essentially, before it even comes to your door, we need to have evidence as suppliers that what we're sort of suggesting here is very safe. I think fundamental, and everyone we talk to, is that it's interoperable. So a lot of the time, clinicians are running around on really busy wards. They do not want to and do not have the time to log into one system over here, log out, log in, log out, log in. Not to mention the stress of managing passwords, etc. Siloed data is risky data. What you really need is a seamless single sign-on in patient context from your central source of truth, typically the electronic patient record, into any tool that you choose to use. Accessibility is key. So obviously the fundamental WCGA standards need to be met, but what organizations out there are thinking ahead of that even further? Have they got voice enablement, eye tracking, giving the usability of multiple languages within their system? So it's about making the tools that you choose accessible and choosing accessible tools. They obviously need to be user-friendly. It's a given, both for your staff and for your service users. And fundamentally, they need to be outcome-focused. So what are we looking at there? Things like, is it offering, improved clinical outcomes? Is it offering cost savings, etc.? Our company, as I kind of introduced at the top of the meeting there, it fundamentally believes that the future of healthcare is preventative, it is community-based, and it is supported by digital tools. So no more reactive acuteness wellness models, because ultimately I think we know we have a limited resource in the healthcare providers in our system. We are all living longer with chronic conditions, and ultimately the system as it stands arguably is not sustainable. Something does have to change for us to be able to manage these people that are living longer with these conditions with a finite healthcare workforce. Just to give you a flavour of some of the use cases and the customers we work with, and I'm going to dig a little bit deeper into just two of these, if I may. In the UK, we work with the Birmingham Community NHS Foundation Trust. In the sort of more acute setting, we work with the Leeds Teaching Hospitals NHS Foundation Trust. In Ireland, at the height of COVID, we were deployed to all primary care providers. All the GPs in Ireland had access to our system. We're also working in over 170 care facilities in Ireland, and we work with a number of mental health care providers and charities, namely Dublin Simon Service the Homeless in Dublin. Accord is a mental health care provider. So I suppose we're agnostic as a supplier to the organization that utilizes our tool. And what's interesting is they all use it in very different ways depending on their own kind of digital pathway needs. Broadly speaking, we have 9 modules, and many of you probably already have some of these components at your facilities. You might have Attend Anywhere in place for video. You might have AccuRx for forms and messaging. There's lots of fantastic tools on the market. What we offer, sort of broadly speaking, are 9 modules, and half of them are clinical and half of them are administrative. So those ones that support things like appointment management, digital letters, messaging, etc., fall into that kind of administrative category, which offer benefits and supports in their own right. But where we're really interested in is the space around clinical management through our clinical modules. So things like symptom tracking, wearable connectivity, device connectivity, allowing organizations to place patients on virtual care pathways where they receive educational material and forms, etc., to support them to be cared for remotely. So it's kind of a pick and mix of modules that our customers implement around the systems that they already have that work well for them. So I'm just going to pause there for a second and sort of dig a little bit deeper into the use case at the Birmingham Community NHS Foundation Trust. And this will give you a little bit of a flavour of that sort of digital experience for one of their service users. So in the first instance, we've integrated with the hospital information system or the electronic patient record on site. It's called Rio. It's a product that Access Group have deployed. And we use NHS Smart Card for staff to authenticate into the system and to log from that Rio EPR into our interface where needed. So a lot of the time things are happening quietly under the hood and there's no need to log in, but when they need to come over to our system, they can do so seamlessly. And it's typically to engage with functionality that the EPR wouldn't have as standard, such as sharing educational resources, sharing assessments with the service user. From the patient's perspective, they would go to the Birmingham Community Trust site, they would log into the system, they would authenticate using NHS login, so that kind of falls under the kind of safety and the DCBO 129 and the compliance piece that we know Joe is Joe before freeing up any aspect of the Rio record into Joe's hands. And from there, depending on what the customer needs, but in this case, Birmingham have asked us to let the patients see their appointments, let them manage their appointments, let them receive letters digitally. And their staff can also then send educational material to their patients. So typically this is curated at a kind of a managerial level. They have evidence-based documents that, in the physio world, I would have handed pamphlets of exercise programs and smoking cessation leaflets and things like that. All of that now is in digital format and passed through the portal to the service user. We also then connect with RIO assessments. So in the EPR, there's assessments that are built out for the patient. We can pull those assessments into the portal for the patient to complete and send that information back. I'll talk a little bit at Leeds what happens when you sort of combine educational resources and assessments. You can put people kind of fully on a virtual care pathway, but I'll come to that in a moment. Another interesting area that we're working on is proxy access. So I know that this is quite a controversial space, particularly in primary care, etc. But we're working quite closely with the trust to understand, okay, well, if it's a parent caring for a child, or if it's an individual caring for a relative who has additional needs, can we in some way securely offer that third-party access to the system? And then they are defining for us at the moment which areas of the care record they would like to free up. So that's, again, giving patient access, giving them educational material, giving them a room to kind of communicate inbound with the facility, and ultimately supporting them to self-manage their care. Another use case is at Leeds Teaching Hospitals Trust. We are on the cusp of going live with this, so I'm very excited hopefully to come back and give you the update on where that has progressed to. But the way that it works is that we integrate with their electronic patient record system. It's called PPM+. They don't use SmartCard, they use Active Directory to allow staff to do a single sign-on again into our system. Equally, patients would come to the hospital site, or they can be invited by their care provider to have access to their record. And again, NHS login is used to validate that service user before giving them access to sensitive information. They can again receive educational material fully curated by the departments in the Leeds Teaching Hospitals Trust, and they can have access to assessments, again, from the EPR, landing into the portal, allowing the patient to complete that and pushing it back. Interestingly, and it's a very exciting proposition in their virtual fracture clinics at the moment. When a patient, let's take the example of, I walk through ED, I have a sort of a stable fracture in my wrist, and normally after being seen, I might need to come back for a follow-up appointment. Where you combine educational resources and assessments and schedule them to go out into a person's hands at sort of set times, you can place a person on a virtual care pathway. So, for example, that stable fracture, before they leave the ED, they get invited to access the record, they get placed on a virtual care pathway. And then from the comfort of their own home, at 2 weeks, at 4 weeks, at 6 weeks, they receive the right material for that stage in their healing process, and they'll receive an assessment to complete. So that at the end of that 6-week process, they could potentially fill in either a self-discharge form or a patient-initiated follow-up form, and that allows a freeing up of the follow-up appointments that no longer need to be attended. And that's a really exciting proposition in terms of giving clinicians back valuable time. And again, the goal of this is to support patients to self-manage and to be cared for from the comfort of their own home. Just kind of summarising briefly who we are, and I know I touched on it. Lindsay also has a background in physiotherapy, and my co-founder Greg is an epidemiologist. So we'd be really welcome if anyone on the call is interested in exploring these pathways with our customers or further with us. I'd be really interested to hear your thoughts, and most importantly, we'd like to hear your needs, and what the needs are in the market in terms of transforming your care pathways digitally. So thank you. I'll pause there and open up the floor to questions, and I hope I didn't race through that.
Thank you, Sonia. If you could stop sharing now, that would be great. That's perfect. There we are. Well, look, while people get their heads together, if you'd like, just raise your virtual hand. We'll come to you and you can ask a question outright. That would be fantastic. Just while they do, the bit that I'm curious about, I suppose, is the extent to which Wellola can help in respect of integrated care across, acute primary care, into social care, even into the voluntary sector. Could you just briefly, while everybody else gets their heads together on this, could you just give some comment about your aspirations or ability in that regard?
Yeah, absolutely. So for the service user, their experience is that they can go to the website of the hospital or primary care or their mental health care provider and log into the system that way. But equally, if they wish to, they can download. We have an app called Portasana, and in Portasana, they have visibility of all of their care providers in one interface. So it's quite a nice centralized experience for the service user, you know, be it residential care, primary mental, public, private even. We work in private facilities as well. They have a singular experience. For us, absolutely, the customers that we speak with are looking for us to integrate with their system of systems. We're working with the NHS Wayfinder to integrate with NHS app. So, you know, for me, that kind of connected experience for the service user and for the care providers that care for them is crucial. And absolutely, it's what we're working on at the moment.
All right, thank you. Well, look, I've given everybody else time to draw breath there. We have Charlotte Lewis, who's got her hand up. You're first, Charlotte. First cab off the rank, as they say. Off you go. Do please ask your question.
Thanks, John. Hi, Sonia. Hope you're well. It's lovely to to see you. I just wanted to be honest, it's not really a question, and John will tell me off if I'm not allowed to do this, but I just want to say hello and thank you for sharing. Actually, that slide deck was really useful. I've worked with Sonia and Wellola before I was on maternity leave, so it's nice to come back to. I just wanted to echo actually what Sonia was saying. I think as an organisation and as a product, for me, Wellola really sort of hits the right balance in terms of, you know, digital solutions, but actually a really good company with the right, you know, morals and ethics behind them. So I do know a lot about the product already, so I didn't have any specific questions, but I just wanted to say hello, thank you. And actually your question, John, around the sort of link to ICS was probably the one that I would have asked, because I think that there's a real opportunity there to do some of that interoperability or integration work. Actually, if we take the sort of tech away, the integration piece that the ICSs are driving at, because I'm not seeing a huge amount of that kind of integration on the ground. But actually, if we can use some technology to make patients feel and users feel like actually there is an integrated care system here that they can benefit from, then I think we will realise some of the actual kind of ambitions really of the whole ICS programme. So I'll shut up now, but thank you.
Well, look, if we can act as a Friends Reunited resource, then that's absolutely fine. I don't have a problem. Do you have a problem with that, Sonia?
No, I feel like I planted her. She was so kind. Thanks, Charlotte. Lovely to see you again.
And if I may, the reason I asked about the integrated care, we've just come off our integrated care special interest group, and we're talking to two fantastic people who were talking about the Isle of Wight and what they're doing on the Isle of Wight from an integrated care. I think I'm right in recalling they said that when they first started looking at how they could better work to smooth the way for patients and care receivers on the island between the different facets of care and health provision. I think I'm right in saying 17 different IT systems from different provider networks and so on. So that's why I got to that. There we are. Shane Tickell has got his hand up. Come on, Shane, you're next up.
Hi, Sonia. Thanks very much for a really interesting overview. I've watched Wellola over the last few years develop, and my congratulations to you on what you've achieved. I think that's great. I know that the challenge is interoperability, but well, I think, are you at Rewired next week? Because I'd really love to just take this conversation forward. I'm delighted to see what's on the website, a little bit more about the application for the end user. I do a lot of work on data normalization. So rather than interoperability, access right the way across health, primary social care, acute. So it's a different way of accessing and providing data, which I just think the interoperability challenge we've worked for the last 20, 30 years is still probably another 10, 20 years away. And actually what we all really want is that data for all the patients. So I think, you know, I'd absolutely delighted to see more and more patient engagement, and our governments in the UK and Ireland promoting that access. And I think the new GP contract this week accelerates that access, so we'll see more and more of it. And I just wanted to congratulate you on what you're doing, and more power to you.
That's really kind. Thanks, Shane.
Another fan, Sonia.
It's great.
Add them to your portfolio.
Anyone that's at Rewired, I'd love to connect. And Shane, that would be fantastic. I'd love that. Thank you.
Jolly good. Okay, any more questions? Doesn't look like it. So I'm going to say thank you to Sonia and the silent but impressive Lindsay. You've been grand, the pair of you. Thank you so much. What an interesting presentation. I need to delve deeper, I think, Sonia, and find out a bit more about what you do and how you do it. But that was super. Thank you so much.